All right, everybody, it is 6 o'clock and we are going to get started with our mock orals for general surgery tonight. The video will be posted on YouTube later this week, and give our examinees a big round of applause for being brave enough to step up and be on the live stream tonight. If there's any last minute questions before we get started, happy to answer them. Otherwise, we're going to take it away with Dr. Hollinsworth and Dr. Schenker.
I do see a hand up.
A hand up.
Eric Mulkey. Am I wrong? Okay.
I can't see that on my end.
Well, then let's get going. All right. Hello. Let's see. You're moving around on my screen. Dr. Hollinsworth. Did I say your name correctly? Yes. And let me just make sure that you are not muted. Can you just?
Yeah. Can you hear
All
me?
right. Great. Perfect. All right. So we are going to start with our first scenario. All right, you are in the operating room with a 62-year-old man. He has a mid-rectal cancer located 8 centimeters above the anal verge. He has received radiation and chemotherapy. The tumor is posterior and bulky. He's in lithotomy position in steep Trendelenburg position for pelvic exposure. In the operating room, after high ligation of your inferior mesenteric pedicle, you proceed to mobilize into the presacral space. Suddenly, the pelvis rapidly fills with blood. Tell me, what are your next steps?
So with bleeding from the presacral region, I'm concerned for bleeding from Batson's plexus. So I would start by applying pressure. I would inform my anesthesiologist that I have some bleeding so they're aware of this scenario. If after applying pressure and checking again, and they're still bleeding, then I would apply hemostatic agent and again reapply pressure and check in with anesthesia.
So you're going to first apply pressure. Let's go back. Tell me more about how you're going to apply this pressure.
So I would start with packing with laparotomy pads and apply pressure directly. Okay. And would check in with anesthesia regarding vital signs and need for any resuscitation.
So you pack with laparotomy pads, you inform anesthesia what's happening. They're on board. They see that his blood pressure has gone from 140s, 150s to about 60. His heart rate is in the 140s. They're still able to ventilate him. And so while the packing is in, you discuss with the anesthesiologist what you want them to be doing. Tell me about that discussion. What are you talking about with them?
Okay, so one, I would make sure that there's blood available for the patient. I would initially, if blood is not in the room, have them start with crystalloid resuscitation, followed by 1-to-1 transfusions. I would continue, if my bleeding is controlled with my packing, I would continue to apply direct pressure until anesthesia feels like they've caught up with his hemodynamic status.
Okay, anesthesia agrees with you. They start with the resuscitation in the manner in which you describe. His blood pressure and heart rate do respond to this resuscitation, so it comes up. How do you assess where the bleeding is coming from now?
So I would remove my packing and assess directly. Sometimes it is difficult to assess one direct area of bleeding and also difficult to repair primarily. So if there was one obvious area of bleeding, I would plan to treat with electrocautery. If it was non-specific area of bleeding, then I would plan to place hemostatic agents and apply pressure again.
Okay. It seems a little bit diffuse in one area, but not an area that you see to cauterize. You apply some hemostatic agents and apply pressure again. When you remove the packing, it's still bleeding. What other methods can you use to control the bleeding?
Another option I have is to place an omental pedicle over the area to help apply some more hemostasis. Am I able to achieve an omental pedicle, and is there still ongoing bleeding?
You put some omentum down there. There's still bleeding around the omentum.
Okay. Additionally, I would ask my anesthesiologist to check a tag for coagulation, just to see if there's any directed resuscitation that we could perform.
While you're waiting on that, they get an INR. It comes back as 1.5. Hemoglobin, which was 12 pre-op, is now about 7 after receiving 2 units of blood and 4 of FFP.
Okay. Since the bleeding is fairly diffuse, if the omental tacking doesn't work, another option is to consider use of an argon plasma coagulation versus most times this bleeding will self-resolve after some time, so might just need some time with hemostatic agents and pressure.
Okay. With your omental pedicle and some additional pressure and hemostatic agents, things are controlled. Again, he now has a blood pressure of 100/60, heart rate of 95 to low 100s. pH is 7.3, bicarb is 17. Hemoglobin with continued resuscitation is about 7. He's about 10 liters positive. What do you want to do as far as this operation? Your bleeding's controlled. It's now been about like 3 hours. He's in steep Trendelenburg. You've taken your IMA.
Okay. Since I've already taken the IMA, I have 2 options that I would consider. The safest, quickest option would be to perform an end colostomy and plan for continued resuscitation postoperatively for his anemia and acidosis. If I felt like I was able to perform an easy anastomosis and it was reaching easily, then I could perform an anastomosis, but would plan to do a diverting ileostomy, as he would be high risk of leak given his acidosis and ongoing need for resuscitation and fluid balance.
But you have a non-viable sigmoid now. So which of those 2 choices are you going to proceed with?
So I would plan to resect the non-viable portion of the sigmoid and perform an end colostomy, as I think this would be the safest option to proceed with ongoing resuscitation of the patient.
Okay, so you're going to do that and you'll leave the rectal cancer there and come back for that?
At this point with the patient's acidosis, I would plan to just resect the sigmoid at this point, oversew the rectal stump, and plan to return to the admission.
And plan to return when?
During that admission.
Sorry, I didn't hear you. I think you froze for a second.
I would plan to return to the operating room if he was stable during admission for completion proctectomy, anastomosis, and would do a diverting loop ileostomy.
When you take him off the table, how are you going to manage his abdominal wall? Are you going to close him? Are you going to send him to the ICU?
I would check in with my anesthesiologist to see how his acidosis is, if he's stable. If I was planning to return in the next couple of days, I think I would plan to place a temporary abdominal closure for resuscitation in the ICU and return to the operating room when he's stable.
Okay, we're going to stop here. That was about 8 minutes, and I'll just need do you want me to go to the next one or debrief at this
time? If you don't mind going to the next scenario, and then we'll debrief both after.
All right, that sounds great. All right, Dr. Hollingsworth, we're going to go over to the next scenario. Okay, you're seeing a 42-year-old gentleman in the office. His history is significant for anoreceptive intercourse, and he notes that he's had 6 months of worsening anorectal pain and bleeding. He endorses altered bowel movements for the last 6 to 8 months. He's had increased straining. He needs to use daily laxatives. He's been eating a softer diet. He doesn't always have a bowel movement every day. He's tried talking to his primary care doctor and has done sitz baths and stool softeners and fiber and everything without any change or benefit. He has not been able to be sexually active for 2 months due to this pain and difficulty going to the bathroom. Of note, he has no family history of any cancers, and other than the social history I gave you, he does not have any significant history for tobacco, alcohol, or drug use. In the past, he's had multiple sexual partners and a remote history of gonorrhea and chlamydia, but for the last several years, he's been in a monogamous relationship.
Okay. So it sounds like I already obtained a lot of the history, but a couple other questions I would want to ask the patient is if he's ever had a colonoscopy in the past, and also if he has any known history of HIV or has been tested for HIV in the past, or any HPV infections.
Yes, he has never had a colonoscopy. He's been tested for HIV negative, including 1 year ago. He has never had the HPV vaccine and does not recall being tested for HPV.
Okay. So at this point, I think I've gotten a lot of my history. So I would plan to proceed with a complete exam, including an abdominal exam, inguinal lymph node exam, a digital rectal exam, and if the patient would tolerate an endoscopy in the office.
So you do your complete exam. His abdomen is soft, non-tender, mildly distended. He has palpable right inguinal lymph nodes. In his perianal exam, it looks normal, but when you try to do a rectal exam, it's too uncomfortable.
Okay, so I would explain to the patient that since I do have a concern for a possible malignancy, I would recommend an anal exam under anesthesia with possible biopsies and perform a colonoscopy at the same time.
Okay, he is agreeable to your recommendations. So he preps for the colonoscopy. That goes okay. You start with the exam under anesthesia. You see that approximately 1 centimeter up from the anal verge, there's a circumferential mass that's about 4 centimeters in length. This is sort of associated with a stricture secondary to the mass. You're able to digitize this with your index finger only. You cannot fit an endoscope in. There is bleeding with the digitation. You do take biopsies at that time. You do your colonoscopy with a pediatric colonoscope, and you're able to get to the cecum. The prep is fair. You're able to wash it out, and you see no other issues. The pathology comes back consistent with squamous cell cancer.
Okay. So I would plan to have the patient come back to the clinic so I could discuss the pathology findings with him. Additionally, given the lymph nodes that I felt on exam, I would also want to obtain a PET CT of the chest, abdomen, and pelvis to evaluate for any suspicious lymph nodes, and would additionally obtain a pelvic MRI for more evaluation of the local area. Am I able to get those imaging before the patient comes back to the clinic?
Yeah, he's agreeable to this. You get the PET CT imaging. It shows a SUV uptake in the anal canal of approximately 15, and the inguinal lymph nodes on the right side are about 12. There is no signs of metastatic disease in your imaging workup other than what I've described in the pelvis. The MRI of the pelvis shows thickening of the anal wall, consistent imaging of that mass, and a slightly enlarged right inguinal lymph node, about a little over 1 centimeter, which is consistent with what you palpated in the office. There is no invasion into any other organs that you can appreciate.
Okay.
You
So
also appreciate on the imaging that his colon and rectum are a little bit dilated and there's a lot of like fecalization.
okay. So I would see the patient in clinic and explain the pathology findings to him. I would counsel him that the treatment would be upfront chemotherapy and radiation with the NIGRA protocol. So I plan to refer him to both medical oncology and radiation oncology. One other consideration I have, if the patient develops any worsening obstructive symptoms, then my plan would be to perform a diverting ostomy while he's undergoing therapy. So we'll discuss that with him as well.
Okay, you discuss all this with him in the office. He is concerned that he's really having a lot of difficulty, like using the bathroom. Is this something that you want to do before he starts treatment, or do you want to see how he does with treatment?
And I think with his symptoms, I would plan to offer a diverting sigmoid loop colostomy, since it was near obstructing on exam and given the patient's concern for his ongoing symptoms.
Okay, all right, so you do your diverting colostomy, he tolerates that well. And I did lose you on the internet for a second. So what is the protocol of treatment you're recommending him for?
So I would recommend the NIGRA protocol, which would be a combination of chemotherapy and radiation, and would refer him to both medical and radiation oncology.
Okay, well, what is that chemotherapy and radiation?
The chemotherapy is 5-FU and oxaliplatin, and I would have to ask my radiation oncologist for a specific dose of the radiation, but would plan to proceed with his neoadjuvant or his chemotherapy and radiation treatment.
Okay, he undergoes his chemotherapy and radiation treatment. When do you see him back?
So I would want to do repeat an examination in the clinic, including a digital rectal and endoscopy if tolerated 6 weeks after his treatment. Do I see any residual findings on my exam?
He has like a 1 centimeter residual finding anteriorly.
Okay. So I would discuss with the patient that radiation effects can persist up to 6 months. So I would not recommend any biopsy or further treatment at this time, but would continue to do serial exams every 6 weeks until he was 6 months after treatment.
Okay, let's say everything resolves and a year and a half later, he comes in with palpable inguinal lymph nodes again on the right side.
Okay, so I would start with referral to my interventional radiologist for an FNA of the lymph nodes to evaluate for squamous cell carcinoma.
You cut out there for a second, but let's say the lymph nodes do have squamous cells.
Okay, so I would explain to the patient that since he's had radiation already, that he would not be a candidate for another round of radiation, and would recommend a inguinal lymph node dissection.
Okay, all right, we will stop there.
Great job. So at this point, we will do feedback from both examiners for the scenario and then scenarios, and then we'll move on to Dr. Hutchison after.
Okay, and how long do we have for feedback?
You have up to 10 minutes.
Okay, all right. Well, let's start with our observer, Dr. Atawa. What did you think?
Overall, I think you did a very good job. We can start first with stylistically, and then we'll talk about the content a little bit. So the one thing I would suggest is instead of naming the options that you have, commit to one option and explain why you're going through the one option or the other. In a lot of scenarios, you're going to see that there's not one right answer. They just want to see how you would handle the patient if it was in your practice. And so as long as you're able to explain why you're doing one thing or the other, and as long as you can support it with the data that you've been supplied with, I think you should just commit to one option and not the other. you do a good job in verbalizing what you're thinking, which is, I think, very good. There's a thin line between, trying to waste time by repeating what you heard and, thinking about all the differential and every option that you have, which you did not do. This is why I'm saying you did a good job. But it's always important to make sure that if you start going down the route, a route that you want to explain, you can do so pretty quickly and pretty succinctly. I think overall you did, we can start with the anal cancer case. I think you managed it pretty well. It's always a bonus point to say, I will present the patient a tumor board, I will stage the tumor. Those are the buzzwords that you can use to very quickly move on through the case. I think overall you manage it well with the chemotherapy, with the chemoradiation, NIGRO protocol. You staged it well. You did the appropriate workup. And the bleeding patient, I think where Dr. Shanker was leading you is to make sure you're thinking, first of all, what you need to do acutely, and you want to think about what's going to happen immediately after the OR and then long-term in terms of the cancer. So those are the things that you have to think about in the case. Always think about making sure you have appropriate access for bleeding in the OR, make sure you have blood available, make sure you communicate with the anesthesiologist, which you did pretty well. And then again, several options to control bleeding. I think you mentioned most of them. You start with some pressure packing. Sometimes the specimen is still in the way, so you do have to dissect a little bit more of the specimen away to be able to see the bleeder a little bit easier. Hemostatic agents are appropriate. You can use a rectus muscle patch to kind of control as well the bleeding. Other than that, once you start having some acidosis, you worry about coagulopathy, medical bleeding, you got to start thinking about Baylats, right? So you got to start about think about leaving the abdomen open. You also want to think about a patient who's had 10 liters of fluid and several units of blood. You want to think about abdominal compartment syndrome. So those are the things that you have to think about in terms of how you manage the patient postoperatively. I didn't see anything that was, a critical mistake in your management. And just, making it a little bit more, organized in the first case. The second case, I think you did very well.
The first
Yeah,
case,
sorry, go ahead, Dr. Helmsworth.
the first case is really tough.
There you go. I love how you broke it up, style and content. We'll start with style. So I like that. Yet you're very like calm, cool, collected, very like when you're confident with what you're saying, precise with the language, very easy to understand like what you're thinking and about, which I do appreciate. So I think all that was excellent. I do think you don't want to, if I like with the sacral bleeding, you don't want to like go down multiple pathways, like maybe I'll do this or that. You do want to commit to something. I also do think though that for yourself and the examiner, it's good to have differentials. Like if I say, hey, the pelvis massively filled up with blood, you can say, this is either presacral bleeding or an iliac injury, and I'm going to pack and, do what you did with anesthesia and then, confirm actually where the site of injury is. And it lets the examiner know sort of that you recognize the anatomy and what the possibilities are. And then they can say, okay, you check and it's like presacral bleeding, or it is an iliac injury. What if that's where they wanted to lead you and, you were like lateral in your dissection and got into the wall. And then they're like, hey, you don't see any presacral bleeding, right? So like, I think just thinking in your head where they could lead you. Same thing with the anal cancer. You could say, okay, it could be a sexually transmitted disease. It could be an anal fissure. It could be a mass. I'm going to take him for an exam under anesthesia and a colonoscopy. Your workup may be the same, but I think just letting them know that you're thinking about appropriate differentials, because you actually don't know which way the scenario is going to go. So it helps keep your mind a little bit open to the responses that they could give you. And that is different than saying, I may do this or that. You can be like, okay, there's massive bleeding. It's either a presacral bleeding or an iliac injury. I'm going to pack and talk to anesthesia and then figure out the location of the injury. So if I go on to content, yeah, I think you did a superior job with the anal cancer than with the sacral bleeding. Certainly, I think the sort of first thing was identifying that it was sacral bleeding and whether it's diffuse or localized. Diffuse and localized are managed differently. And if Stevie wants it, I have like associated articles that I used for the scenario. So if you want to post those or put those out, I can give those to you.
That would be great.
Excellent. But you want to say, hey, is it diffuse or localized? If it's localized, you may talk about more standard things like a thumbtack or helical tack or like bone wax or something like that. If it's more diffuse, you want to talk about like the rectus muscle. Sometimes they use breast implant expanders and things like that to temporarily put there. And then depending on the response of the patient, sure, you want to say like, am I getting off the table right now and just going to the ICU, taking out like the dead part of the specimen, or am I going to finish? That was your next decision-making point. And it still has to, you still sort of want to go for the oncologic finishing. And I think, Dr. Atala read my mind that I was going to lead you to compartment syndrome if we kept going down that road. I think those are the things I would say about the content of that first operation. The second one with the anal cancer, I think, yes, you sort of like nailed everything. And I think just being familiar with those NCCN guidelines for your boards for all the cancers. You did ask me about HIV, which was great. I think the appropriate workup, you could still tested for HIV, talk about fertility, et cetera. That was important. But sure, you got the imaging, you do the colonoscopy. You were right on about the surveillance and the groin dissection, and about the diversion. So I think you hit all the necessary like content parts with that as well. I do think some of those key buzzwords is, first saying like, hey, my differential is 1, 2, and 3, and I'm going to take him to the OR. I think also giving me a clinical stage of the tumor. I gave you the information so you can say it's a stage 3A, T3, and 1, and 0. I'm going to present him at tumor board, and this will be my recommendation. I'll see if my colleagues agree, and then go from there. But you certainly got all the content things right.
Thank you. Those were really good scenarios.
All right. Well, thank you.
Can I add one additional comment as well? So
Yeah.
that's for everyone. So the first case was a very typical, management in the OR. We weren't asking about disease process, about staging, history, physical, which you can definitely get that in the oral boards. And on the other hand, you can also get a patient who's post-op, who's in septic shock from a UTI, and it will be all, management of, infection, pressors, all of that. So just because this is general surgery board does not mean that you always have to be in the operating room. And on the other hand, you can also have a case which is 100% in the operating room and talking about management, surgical management of patients in the OR.
Agree. Yes.
Okay, and then one quick reminder, if anybody on Surgeon or in the Zoom chat has questions, please feel free to type them and then we can address them at the end. But now we will move on to Dr. Hutchison and Dr. Atala.
All right, Dr. Hutchison, you are seeing a 67-year-old woman in clinic who is seeing you for a liver mass. She presented to the emergency room about a week prior to seeing you with upper respiratory tract symptoms. And then she had a CT scan of the chest, abdomen, pelvis, and the ED, which showed a 3 centimeter hypoattenuating mass in segment 6 of the liver. The mass has irregular borders. There were no other abnormalities that were seen on the CT of the chest or the abdomen. The patient has a history of hypertension, hyperlipidemia, and diabetes, all well controlled on medications. And she comes to see you for management of this liver mass.
Okay, I would complete my history and physical examination. It sounds like I have the majority of the history from the stem, but I would inquire about previous colonoscopies, any family history or personal history of cancers, including colon cancer.
She has no family history of colon cancer or other types of cancers. Her last colonoscopy was at the age of 60, and at that time they cleared her and told her your next one will be in 10 years. She has no other symptoms, no abdominal pain. Her appetite was normal, no weight loss.
Okay, and then I would complete a physical examination focusing on the abdominal exam, as
Oh.
well as discussing whether or not she said she didn't have any other symptoms, but making sure there was no evidence of bleeding on digital rectal exam.
Okay. You do an abdominal exam, that's normal. You do a digital rectal exam that shows no sign of bleeding or any other abnormalities.
Okay, so based on the description of this mass, this incidental liver mass on her emergency department CT scan, I'm concerned for possible metastatic disease to the liver given the hypoattenuation. I would discuss with her my plan for moving forward with repeating a CT scan as a triple phase liver protocol, as well as sending some laboratory studies to include a CBC, a CMP, a CEA, and an AFP, as well as some nutritional labs.
Okay. Nutritional labs are normal. Her CBC and CMP are both normal. Her AFP is 12. Her CEA is 32. You repeat the CT scan, triple phase CT scan, shows the same mass, a 3-centimeter mass with irregular borders and segment 6. That is suspicious per the read for metastatic cancer.
Okay. So at this point, I would discuss with her next steps regarding proceeding with the colonoscopy to evaluate for possible colorectal primary, as well as discuss with my IR colleagues for percutaneous biopsy of this presumed metastatic lesion to evaluate for primary.
Okay, so you get the biopsy of the mass percutaneously by IR, and the pathology comes back as adenocarcinoma of GI origin. You perform the colonoscopy, and you find a 3-centimeter mass in the distal sigmoid, about 20 centimeters from the anal verge. You biopsy that mass, and it comes back positive for adenocarcinoma.
Okay. At this time, I would want to complete my staging workup. I would evaluate whether or not the patient had had imaging of her chest during her emergency room visit, and if not, then I would obtain a CT scan of her chest to complete the staging, and then plan to discuss her at multidisciplinary tumor board.
Okay, so you do review her CT of the chest, and it's negative for any metastatic disease. You present her in tumor board. What are you going to talk to her about?
I'm going to discuss with her that this is, or discuss with the tumor board that this patient has a primary colorectal cancer with evidence of a single metastatic lesion to the liver. And because of that, I believe that she would qualify for a synchronous resection of both the primary tumor as well as a metastectomy. And so I want to discuss that with my hepatobiliary colleagues as well as with my medical oncology team, with plans for adjuvant chemotherapy following resection.
Okay, so you decide to proceed with a combined resection since you're proceeding with your HPB colleague. They start with the liver resection, and then they call you in the room to complete the operation. Can you describe to me what you're going to do?
Yes, so since this is a sigmoid cancer, I believe we said 8 centimeters above the rectosigmoid junction, I would start with the medial to lateral dissection by dissecting the mesocolon off of the retroperitoneal structures and take that from medial to lateral. I would move towards proximally until locating the IMA. I would perform a high ligation of the IMA and then continue that medial to lateral dissection up to the level of the sigmoid the splenic flexure in order to ensure adequate length. I would then proceed with the lateral portion of that dissection, again, taking it all the way up to the splenic flexure. At that time, I would then choose my resection margins based off of the appearance of the colon to ensure that there was adequate blood supply both proximally and distally. And then I would plan for a end to side stapled anastomosis after passing the specimen off the field.
Okay, so you resect the tumor, the specimen is out. You're trying to do the enterocystic anastomosis, and the colon does not reach down to the level of the rectal stump.
Okay, so at this point, I would then return to the proximal margin to ensure that I have a complete medial mobilization to ensure the most length as possible to see if we have adequate length at that point.
Okay, you have the complete medial
It's still
mobilization,
not long enough.
IMV, high ligation. What else can you do to make a reach?
So then I could plan to start taking some of the gastrocolic ligament to see if that provides any further length. And if that is not enough, then I can, using an energy device, take a little bit of the mesentery as long as they are appropriate arcades to continue perfusing the proximal margin.
Okay. You do that and you completely mobilize the splenic flexure. You take the gastrocolic ligament, you take the mesentery all the way to the middle colic, and there's still some tension on the anastomosis. Do you have any bailout you can think out about?
Yes, so the bailout in this case would be to proceed with an end colostomy rather than a primary anastomosis, which is a reasonable option given that this patient is going to require systemic therapy postoperatively, and I would not want a less than ideal anastomosis in this patient, in any patient, but particularly this patient.
Okay. I think we're a little bit more than 7 minutes, so I think we can move on to the next case. So you are seeing a 42-year-old man in clinic who is presenting with pneumaturia. He has had 2 UTIs in the last 2 months. They were both successfully treated with antibiotics. He has a history of diverticulitis with 3 episodes treated in the last 2 years with antibiotics as outpatient. The most recent one was about 2 months ago. He has no other past medical or past surgical history. There's no relevant past family history either. He had labs drawn 2 weeks ago showing a normal white cell count, hemoglobin and electrolytes, and a normal kidney function. He also had a urinalysis at that time that was positive for red blood cells, white blood cells, and for some bacteria. How would you like to proceed?
Okay, I would complete the history in this case discussing his previous diverticulitis episodes and whether he has had any recent symptoms beyond the episode 2 months ago, including abdominal pain, difficulty having bowel movements, if he has had any obstructive symptoms, if he has had any evidence of rectal bleeding, any systemic signs of infection such as feverish chills, etc.
He has none of those symptoms. He has a pain that he develops with the episodes of diverticulitis, but no other symptoms outside of those episodes.
Okay, and then, I'm sorry, you cut out there. What was that?
Sorry, he's seeing you for the pneumaturia. He just
the pneumaturia. Okay. Has he ever had a colonoscopy before, and does he have any evidence of fecal urea or just the pneumaturia?
He doesn't have fecal urea, just pneumaturia, and he has never had a colonoscopy.
Okay, so I would discuss with him that my largest concern at this point is a colovesical fistula secondary to his previous episodes of diverticulitis. But with that in mind, this could also be a cancer leading to these symptoms. And so I would recommend cross-sectional imaging with a CT scan of the abdomen and pelvis with both IV and rectal contrast, as well as scheduling him for a colonoscopy.
Okay, you see on the CT that you order diverticulosis at the level of the sigmoid colon with some mild thickening of the sigmoid of the colon wall. The contrast stays in the rectum, does not go anywhere. There's a small amount of air in the bladder. And then you do a colonoscopy, which shows some mild inflammation at the level of the sigmoid colon. You're able to pass the scope without difficulty through that area all the way to the cecum. You see 2 small subcentimeters adenoma, one in the ascending colon, one in the transverse colon, that are completely resected.
And no evidence of masses or strictures in the area of concern in the sigmoid?
No masses or strictures.
Okay, so at this point, I feel fairly comfortable that this is an inflammatory response causing a colovesical fistula, and I would discuss with the patient the rationale of proceeding with operative intervention to control his symptoms to prevent future episodes of sepsis secondary to urinary tract infections.
Okay, so you would offer the patient surgery?
I would.
Okay. Can you tell me how would you would proceed?
Yes, so I would plan to proceed in a minimally invasive fashion. Given the inflammation around the sigmoid, I would plan to do a cystoscopy prior to the abdominal portion of the surgery to place a stent in the left ureter. I would then proceed with a minimally invasive sigmoidectomy with ligation of the colovesical fistula. This would be done in the standard fashion, starting with the medial to lateral dissection of the sigmoid colon. Taking care to visualize the ureter while doing this dissection, given the inflammation that I'm expecting to find. When finding the tract between the colon and the bladder, I would ligate this with an energy device, then complete the lateral portion of the dissection, resect the inflamed sigmoid, taking care to remove the entire sigmoid colon to prevent future episodes of diverticulitis, and perform a side end-to-side stapled anastomosis with plans to leave the Foley in place. Prior to finishing the abdominal portion of the operation, I would perform a leak test of the bladder to ensure there is no defect there that would need closure while in the operating room.
Okay, so before you actually do the anastomosis, you notice that there's some pooling of clear yellowish fluid in the pelvis. And upon further inspection, the ureter that you had identified earlier in the case is seen to have a near circumferential injury on the left side that is located just distal to the iliac bifurcation.
Okay, so at this point, I would convert to an open procedure. I would contact my urology colleagues to join me in the operating room, and while waiting for them to arrive, I would examine this near circumferential injury to see if this is a cautery injury, if this is something from sharp dissection, so that I can further plan my repair.
It looks like it's a cautery injury. Your junior attending, you're operating at 8 p.m. They're not available for the next 2 hours.
Okay, so since this is suspected to be a cautery injury, I would plan to debride the 2 edges of the ureter back to healthy bleeding tissue. And then depending on the gap between the 2 ends, I would then decide on a repair.
What kind of repair would you decide? Let's say,
So
go ahead.
if it's less than 2 centimeters, I would plan for a primary repair over a stent. I would do that with a running monofilament suture. And if it's larger than 2 centimeters, since it's just distal to the bifurcation, then I would plan to re-implant the distal end into the bladder, performing a psoas hitch if necessary to get the appropriate length.
Okay, you do that, you finish the operation, everything goes well. On post-op day 2, the patient is tachycardic to 130 and diaphoretic with soft blood pressure. He has rebound tenderness, he has guarding. How would you proceed?
So as I'm at the bedside and have my exam of this patient, I would immediately start crystalloid resuscitation, given concerns for possible sepsis causing his symptoms. I would obtain an EKG to evaluate if there's any cardiac cause for his tachycardia. I would send laboratory studies, including a CBC as well as a BMP, and start broad spectrum antibiotics.
Okay, you do all of that. White cell count is up to 23. You start antibiotics, you start IV fluids. What are you doing next?
Okay, so the next steps is going to be a CT scan of his abdomen and pelvis to evaluate for intra-abdominal causes of sepsis. My main concern at this point is a possible anastomotic leak versus a urinary leak.
Okay, all right, I think we can stop there.
Yep, thank you. All right, we'll move on to feedback again. We can start from Dr. Shanker as the observer, and then we'll move on to Dr. Attal.
Oh, and stylistically, you're great, as I knew you would be. And I just have to say, Dr. Stapler, both our examinees are very courageous for being here on and help a nice job. And so I really thank you and both of you. The first scenario, there are many ways you can go with like a metastatic colon cancer. I will say my experience and people's after me experience the oral boards, they do ask complex questions. My very first one was a really complex rectal cancer in the general surgery board. So like, I think everything is on the table. Probably for metastatic disease, some things that you can ask for, like style is perfect. And maybe you did it, you can correct me if I didn't hear it, is like MMR stability. And then, you know, for metastatic disease, I think a lot of times we may consider neoadjuvant first. If they're obstructed or something else is happening, we may first go to the operation. It's not necessarily wrong. There, you know, metastatic disease that goes to the OR is much less common. But I think that, you know, you already said, hey, I'll present them at tumor board. I want to know about microsatellite instability or MMR stability. That sort of impacts adjuvant treatment, response to therapy, all that type of stuff. And of course, our metastatic diseases can get immunotherapy. So that differentiates them from non-metastatic disease. It also gives you a chance after they go through that adjuvant therapy to see if they respond or like blossom, and maybe there were more hidden mets in there that you didn't like totally know about. That being said, I think for the cancer operations, you always want to say, I'm going to go in and do like a diagnostic laparoscopy, or if you're open, I'm going to feel around and look for other metastatic disease just as a step of the operation. I thought you described your operation well. I don't know, maybe Dr. Atala, I don't know if you were thinking of taking the IMV as part of your additional maneuvers, but I think you talked about all maneuvers. I think it's totally reasonable to say, hey, I can't get it to reach. I'm going to make a stoma because she has to go on to like therapy. So I think you thought about it, justified it. You know, giving somebody a stoma will inevitably add some length to that colon over time. It's like a stretch. So I think that was totally fine to do if you've maxed out all your maneuvers. You can mobilize the rectum up. And so you can go into the presacral space and take lateral attachments, and you can get like a lot of work on your centimeters there. So those are just awesome things you can think about content wise. And I think yeah, the colovesical fistula, you know, obviously you did the stent, you talked about managing the injury, started to work up the postoperative complication. I thought that was very thorough, orderly. So so good job.
Thank you.
Yeah, I echo everything Dr. Shanker said. I think you were confident, you gave the right answers. I think you asked the appropriate questions. If we want to go with the first case, exactly that Dr. Shanker said. There's no one way to manage metastatic disease, metastatic cancer. There are some things that I would say, if I had told you the patient can't pass stool, we can't put the scope through it, then it would be wrong to say, well, let's go give him chemotherapy for 6 months. So there are certain things that would push you to go to the OR or not go to the OR. But outside of that, I gave you a metastatic lesion that is easy to resect. I gave you a tumor that is not very low. So it's not inappropriate to have gone straight to surgery. Yes, that's true. A lot of, oncologists would have recommended chemotherapy before, but it's not wrong to go and do a combined resection and then do adjuvant chemotherapy. The one thing that I would have you always ask about whenever you get a colonoscopy that says, 20 centimeters from the anal verge, always ask about a tattoo, right? In real life, I know all of you have already seen this probably in the last 3 months. Tattooed or not tattooed, or 20 centimeters, which is at 10, or 10 centimeters, which is at 30. So that's one thing that I would add to your management. In terms of maneuvers to get the colon to reach, you handled it perfectly well. Whenever you can't get it to reach, a colostomy is always a good bailout. And like Dr. Shanker said, the patient needs to get to chemotherapy. So you can't make an anastomosis under tension and have them get complications and not get chemo. So I think you handled it very well. A couple of other maneuvers that you can probably say to impress your examiner is the lawyer's maneuver. So the 180-degree rotation after you take the middle colic. or a ileal window as well. Those are two things. I don't think they're in the scope of general surgery boards. They're more colorectal boards, but those are two things that you can also mention. For the colovesical fistula, it's one of those cases where I gave you all the information at the beginning. I just want you to go and tell me about the workup and the surgery. So it's okay. You didn't, waste a lot of time asking more questions and all that. You very specifically asked about a couple of questions, and then you moved on to the management, which was the right thing to do. I think, what else did I put in here? A good job talking about ureteral stents, cystoscopy and stents. I mean, that's something that is not, no one will fail you if you don't put stents in, but it just makes them think that you're actually thinking about the problems you're going to encounter during surgery and after surgery. So it's always good to talk about these. The other thing that's important about these cases is that the fact that it got to the injury, to the ureteral injury, and then to the leak afterwards does not mean that you did anything wrong in the case or in the management. They want to ask you about how you would manage complications. So just the fact that you got a ureteral injury, even after you said that we actually identified the ureter, does not mean that that's a negative point. That's how the case was going to go, regardless of what you did during surgery. The other good thing that you said is I would convert to open. You're not going to repair a ureter laparoscopic or robotic, no matter how good of a MIS surgeon you are. So that's a good thing. The one thing I would criticize is when you have someone who's tachycardic to 130 and with soft butt pressures and and septic shock, you don't want to go to the CAT scanner. You have rebound tenderness, you have guarding. It will be appropriate to go straight to the OR to re-explore the patient. But outside of that, I think you did very well. I think both examinees did very well today. So congratulations.
Yeah, you guys, thank you so much for volunteering. Again, like Dr. Chinker was saying, it's very brave of you guys and we appreciate it. There is one question from the Zoom chat to the examiners, and it's just about mentioning calling your senior partner about the reach, or just kind of throwing that in as a line, like I would call my senior partner in, and just what are thoughts about that?
I think it's never wrong to mention it. They're never going to say, okay, you did the right thing, let's move on to the next step. So it's a good thing to say that you're going to ask for help. It's the same thing as calling for urology to come and help you with your injury, but they do want you to know the answers of those questions, and not necessarily exact details about how you're going to repair the ureter, but the concept of how you're going to repair it, and the main ideas behind it.
Yeah, I echo that. I think, there, like in oral board world, when you say you're going to do something, you're going to do it. They're not going to say like, hey, you've only been practicing a month. Like if you say, hey, I'm going to do like a minimally invasive proctectomy for this cancer, I'm going to do these things, for these scenarios, like you can do them. And it's not about real world, how long you've been practicing or who else you can call. So I think like, you're not like in the scenario saying like, hey, I'm not good enough to know how to mobilize things, or they're not going to say like your senior partner comes in and tells you to rotate the colon like 180 degrees. So I think for the scenarios, what you say you have capability to do, they're not going to like turn around and be like, hey, Dr. Hollingsworth, how many robotic cases have you actually done? Like they're going to be like, okay, you do it, and this is what happens. So I don't know if that's a key point. I think sometimes they will ask you, like if you're like, hey, I'm going to do an upper endoscopy for bleeding, or maybe inject vasopressin, and they may ask you for something that's not always in general surgery, like, will you do it or somebody else? And if you say you're going to do it, that's great. Just then know how to do it. They may ask you that. So in the case of repairing a ureter, you should know how to repair that, especially for these scenarios.
Great, thank you. And I don't see any other questions on Sturgeon or Zoom. So just friendly reminder to sign up for our mailing list on our website, go to our YouTube channel, press subscribe. We have content almost every week. We're off for most of the national holidays, and for upcoming boards. So I hope everybody has a great weekend. Good luck for all those taking it in October. And thank you again, Dr. Schenker, Dr. Attal. We really appreciate your time tonight.
Great. Thank you.
Thank you,
Have a
guys.
good night.
Have a good one.